This is the trauma session, and we have FP147, primary AGV implantation in angle recession glaucoma following blunt trauma in Indian eyes.
Good afternoon, everyone. I'll be presenting my study on primary AGV implantation in angle recession glaucoma following blunt ocular trauma in Indian eyes. It was a retrospective analytical study and was done in a tertiary level hospital. 52 patients of angle recession glaucoma were studied from March 2006 to February 2017. The study was approved by Institutional Ethical Committee. Pre-op data included age, sex, type, and mode of injury, duration of injury, assessment of BCVA and IOP, intraocular pressure, DVA, and number of anti-glaucoma drops were studied preoperatively and post-op up to 3 years follow-up. The criteria for successful outcome were assigned as absolute success if IOP was less than 21 or more than 8 millimeter without anti-glaucoma medication during the period of follow-up. Qualified success was assumed if the IOP was maintained to less than 21 millimeter of mercury with up to 2 anti-glaucoma medication after 1 year without the need of additional glaucoma surgery. Failure was defined as uncontrolled IOP with the requirement of more number of anti-glaucoma drops or progressive field changes and poor visual acuity or additional glaucoma surgeries. In the result in the study population, we saw that there were approximately 70% males and 30% females. In sports and RTA, road traffic accident, it was seen that more number of males were involved, but in domestic injuries, the females were more affected. The kind of sport, it was seen that racket game had maximum number of cases in our study, followed by basketball or cricket games. Some patients were having cricket, were firecracker injuries, golf, gulli danda, and boxing. Mean age of the patient at the time of presentation was around about 27 years of age. 73% patient had hyphema at the time of presentation. It was seen that most common site of angle recession in our studies in all the mode of injury was superior, followed by temporal, and then inferior and nasal. This is a graph showing the most common site of angle affected by various mode of injuries. This is the angle of extent of angle recession shown by gonioscopy seen in all the patients and various mode of trauma. Out of 52 patients, 38 patients underwent primary AGV implantation. The mean IOP at the presentation was 40 millimeter of mercury. The mean IOP on maximum topical and systemic anti-glaucoma medication was 24 millimeter of mercury. Following primary AGV implantation, the mean IOP was significantly reduced over a period of follow-up up to 3 years. This is the graph showing mean IOP in the follow-up of study population. The number of anti-glaucoma drugs also reduced from 4 to 1.5 after AGV in first year, and from 3.9 to 1.2 at 3 years follow-up. 3 patients out of 38 were considered as surgical failure who were refractory to treatment and presented with progressive visual field changes. These were the pictures, some of the picture of these cases pre-operative. At the time of presentation, hyphema was most commonly seen in these patients. Also traumatic uveitis. Gonioscopy was clinching investigation to diagnose angle recession glaucoma, and patient presented with more than 180 degree of recession were found to have more incidences of having angle recession. UBM and ASOCT were also done to see the structures. The most interesting fact was that 60% patient with blunt trauma will develop some degree of angle recession. Only 20% may develop angle recession, but there is strong association of traumatic hyphema leading to angle recession. Up to 60 to 100% cases may have traumatic hyphema in these patients. Eye with angle recession, approximately only 1 to 20% may develop glaucoma, and if there is recession glaucoma in one eye, there is 50% risk of fellow eye having primary open angle glaucoma. The management included medical, laser and surgical, but in angle recession glaucoma, there is hardly any role of medical treatment. If there is a development of glaucoma, laser also has a minimal or no permanent cure. Surgery in form of trabeculectomy and glaucoma drainage devices are the most common modalities, but trabeculectomy is seen with high rates of failure rates. The glaucoma drainage devices have been used in cases of recalcitrant glaucoma, secondary glaucoma, and in our studies we have used them as a primary surgical modalities. This is a post-op AGV clinical image. To conclude, surgical management of post-traumatic angle recession glaucoma is a challenging task. Considering the demographic profile and age of the patient, this is a challenging glaucoma to deal with. The limitation of our study was the small sample size, and ideally we should have done a RCT comparison between the primary and secondary AGV implantation in such patients. Thank you.
Just a couple of questions. One is what was the time after trauma that you first checked the eye?
Along with the vision. But in case if eye is very inflamed and all, we would be doing it in the subsequent follow-up. Gonioscopy has to be done once the eye is quietens. It may take a few months also, but once the hyphema is resolved or traumatic uveitis is resolved, then we would like to do the
angle recession. If it occurs, it doesn't really
occur immediately, sir.
The IOP rise will not happen immediately.
Yes, sir.
Secondly, in one of the slides you showed there was cyclodialysis.
Yes, cyclodialysis we have excluded, sir.
Excluded.
It is an exclusion for AGV implantation, sir.
So you said, you said 1 to 20% will develop glaucoma and angle recession.
May develop, sir.
Yes. So what was the total number of blunt trauma you have seen? You said the 38 patients.
Sir, we had 52 patients. Out of that, 38 developed angle recession glaucoma, sir.
Okay, so you have more than 60% actually.
Yes, sir. So we are from Armed Forces Services, where
the development of glaucoma following trauma.
Yes, sir. That is more, sir. Yes.
Any complications with the AGV later on follow?
So we had seen 3 failures, sir, out of 38 patients, sir. The failures were because of persistent hypotony, or maybe, sir, there were macular changes because of trauma, and and progressive visual field losses, sir.
Thank you.